Okay, but it's recording?
Yeah.
We can get started. Okay. Welcome, everybody. Just wanted to thank you all for joining us today in person and online. So this is a bit of a celebration today. It is our 40th What's New in Addiction Nursing session. Yeah, it's a big deal. So yeah, we're very, very excited today. And I just wanted to take a moment to introduce our presenter today, Karen Edwards. Karen has over 30 years of nursing experience, has been really focused on providing quality patient care and also supporting younger generations of nurses coming into the field. She's got a background as a clinical educator and through the program is continuing to build on her wealth of knowledge to share with her colleagues. All right, and so I will hand it over to Karen. I'll just let the group know. Usually we'll have some time reserved at the end of the presentation if there's any questions. And then if you're joining us online, you are welcome to just pop those questions into the chat and we'll read them out after. All right, here you are.
Okay, good afternoon. Thanks for joining us. My name is Karen Edwards. I'm a clinical resource nurse educator with Withdrawal Management Services through Vancouver Coastal Health. And today I want to focus on neonatal abstinence syndrome associated with antenatal exposure to benzodiazepines due to the toxic drug supply. To start off, I just want to respectfully acknowledge that I'm a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I have no conflicts to declare today, and a brief outline of what this presentation is going to look like. So we're just going to go through the objectives, a little bit of background, any related issue, literature towards the issue, and application to practice, and there will be a list of references at the end. The objective today is to kind of start that conversation around neonatal benzodiazepine withdrawal and to kind of check to see if there's any research around treatment options for this. So a brief overview of what benzodiazepines are, okay? They're a class of depressants used to treat a variety of conditions in social anxiety disorder, seizure disorders, and panic disorders. Benzodiazepines alter the activity of the neurons that trigger reactions. They may help with bipolar disorders and tics when used off-label. And these medications are often safe and effective when used appropriately. However, they may cause tolerance and dependency and other issues over a longer period of time. Some side effects include depression, confusion, drowsiness. Okay. So what's the significance of studying benzo withdrawal in newborns? Studying this will assist in enhancing clinical outcomes. The studies on the benzodiazepine withdrawal in infant informs clinical management and practices. It guides policies and guideline formulations. So the research on the effects of benzodiazepine withdrawal in infants may help shape healthcare policies and procedures by providing evidence-based recommendations and helpful guidelines. Increasing public health awareness. It helps when research is done on the effects of benzodiazepine withdrawal on newborns. It helps us shed a light on the public health issues surrounding the use of medicine by mothers during pregnancy. What leads to benzodiazepine exposures in babies? So, exposure happens or usually occurs when mothers use these drugs during pregnancy, and it's either when it's being prescribed as a prescription for other conditions, i.e. anxiety or seizures. Another factor that might increase the risk of prenatal exposure with benzodiazepines is people with substance use disorders. A fetus may become dependent on benzodiazepine when a pregnant woman uses the drug or other substances that are contaminated with benzodiazepines, namely fentanyl. Once born, the infant experiences withdrawal symptoms as the body adjusts to the absence of the drugs. All right. So the term for newborns experiencing withdrawal symptoms is referred to as neonatal abstinence syndrome. And this is the condition where various symptoms may appear in newborns as a result of the withdrawal from prenatal drug exposure. It is often linked to the use of opioids by mother in the recent years that have been a 5-fold increase in the prevalence of NAS, leading to a corresponding risk in hospital expenditures. NAS babies have increased risk of death and neurodevelopmental disorders in the long run. Some of the symptoms of NAS includes restlessness, tremors, trouble eating, and trouble breathing. Opioids tend to be the most common cause of NAS, although other substances such as benzodiazepines can also lead to NAS. Babies born with NAS may face a variety of challenges, both immediately and in the future. Some of the challenges faced includes issues with eating, breathing, and low birth weight, and delays in development, and a higher chance of behavioral and cognitive issues. Some of the neurological symptoms may include restlessness, tremors, hyperactivity, and convulsions. Respiratory distress, this may also include breathing at a faster rate or having difficulties in breathing, and apnea, which is temporary breathing cessation. Difficulties in feeding. Newborns going through benzodiazepine withdrawal may have difficulties in feeding, such as weak feeding and poor sucking reflexes. Supporting families impacted by substance use disorder and improving outcomes for newborns with NAS both needs early diagnosis and early intervention. Some of the steps used to diagnose NAS include examining the symptoms this infant is experiencing and taking into account the mother's history of substance use when pregnant. NAS treatment options include a conducive environment, proper nourishment, and close monitoring of problems, amongst others. The use of pharmaceuticals, such as morphine and methadone, to alleviate the withdrawal symptoms are used in extreme circumstances. The prevalence of benzodiazepine exposure during pregnancy is relatively or was relatively rare. However, studies relating to benzo withdrawal amongst newborns are less compared to studies on the opioid exposure. There may be an inadequate information on the frequency of benzodiazepine withdrawal in infants, since benzo usage is less prevalent during pregnancy compared to the use of opioids. And what that means is because the primary focus, substance of choice is listed as opioids, then benzos are not particularly looked at. While some studies have shown a decline in the use of benzodiazepines during pregnancy, others have shown an increase. Okay, some of the factors such as the frequency, duration, and the dose of the mother's benzodiazepine usage, as well as the individual variations in metabolism and pharmacokinetics would determine the occurrence of benzo withdrawal in the infant. Finding an accurate prevalence rate for benzodiazepine withdrawal in infants is challenging due to the limited studies and diversity in clinical presentation. Some of the importance of doing study in this area is to enhance maternal fetal health outcomes, to have a better understanding of the hazards connected with benzodiazepine use during pregnancy, and addressing the knowledge gap. Healthcare practitioners may better serve pregnant women and their babies if they have a better understanding of the hazards connected with benzodiazepine use during pregnancy. This knowledge can then be used to develop a clinical practice recommendation. The effects of benzodiazepine exposure during pregnancy in the health and development of the baby is crucial and the topic in the field of perinatal medicine. Addressing the knowledge gap and developing evidence-based methods for detecting and treating newborns exposed to benzodiazepine requires continued research. So I did some digging and I found literature around benzodiazepine withdrawal, but there was nothing current and nothing with an outcome as to how will this inform our practice moving forward. So Elfthariou et al. In 2017 studied the neonatal effects after selective serotonin reuptake inhibitors and benzodiazepine administration during pregnancy. They did 26 neonates who were exposed to the SSRIs and SNRIs while still in utero. They did their weight, their age, and at birth, the length of stay in hospital, and benzodiazepine exposure and the existence of symptoms potentially related to neonatal abstinence syndrome was noted. Some of the findings from that research, they found that the risk of symptom development was greater in neonates whose mother were given benzodiazepine in addition to SSRIs or SNRIs than in neonates whose mother did not receive benzodiazepines. Those born with symptoms had significantly lower birth weights and gestational ages compared to those delivered without symptoms. Nelson and Bradshaw did a study on benzodiazepine and anxiolytics in neonates, and they wanted to investigate the current knowledge on the use of benzodiazepines in neonates. They did a literature search, and this was conducted in the electronic database of PubMed. And the search specifically focused on the full text papers published between 2007 and 2012. And their findings, they found no evidence to suggest that exposure to benzodiazepine during the first trimester of pregnancy increases the risk of major malformations. However, in the second and third trimester of pregnancy, exposure to benzodiazepines may lead to certain negative reactions in newborns, including withdrawal symptoms and infant floppy syndrome. Belantuono and Mertinellini conducted a study in 2019, and it was an overview of significant studies that examined the risk of significant birth defect and major malformations and difficulties during the childbirth perinatal complications in babies whose mothers were exposed to benzodiazepines and Z drugs during pregnancy. Their finding, there was no evidence suggesting that exposure to benzodiazepine during the first trimester of pregnancy increased the risk of malformations. However, in the second and third trimester of pregnancy, exposure to benzodiazepine may lead to certain negative reactions. San Lorenzo et al. Carried out another study in 2019, and they wanted to see the increased severity of neonatal abstinence syndrome associated with concomitant antenatal opioid and benzodiazepine. They used individual level data linkage of vital records and administrative data. And from that, their findings, they found that benzodiazepine exposure was shown to be significant predictor of pharmacologically treated NAS in a group of babies who had exposure to many substances during pregnancy. Iqbal and Soban and Rials in 2002 did a review of the effects of commonly used benzodiazepines in the fetus, that neonates and the nursing infant. Benzodiazepines are often used during pregnancy and breastfeeding, although there is less evidence regarding how they affect the developing babies. The information that was available was not adequate to determine whether the benefit of benzodiazepines outweighed the risk to the fetuses that were exposed to it, and the potential risk to the developing baby, both during and after the pregnancy, must be considered alongside a drug's therapeutic efficacy. Shiken et al. Also did a review in 2019 on benzodiazepine in pregnancy. The number of people using and becoming dependent on benzodiazepines is rising, and so is the number of fatalities caused by the overdose of opioids and benzodiazepines. Both anxiety and the use of benzodiazepine anxiolytics during pregnancy increase the risk of premature birth and low birth weight. There is a risk of substantial physical dependency and withdrawal symptoms while using benzodiazepines. Wang et al. Also looked at the prenatal exposure to benzodiazepine and Z drugs and the risk of adverse neurodevelopmental outcomes in offsprings. Mothers exposed to the different benzodiazepines and Z drugs during pregnancy and the effects on their children's cognitive, emotional, behavioral, and motor skill development were examined in a systemic study. 19 research papers were considered. The issue of benzodiazepine and Z drugs has been remarkably studied despite several reports of links between these substances and adverse effects in various areas of neurodevelopmental. There is need for more studies. And Grigordes et al. In 2020 did a systemic review and a meta-analysis on pregnancy and delivery outcomes following benzodiazepine exposure. And from this, they found that statistically significant correlation between prenatal benzodiazepine exposure and an elevated risk of various poor perinatal outcomes. Dave et al. Conducted a study in 2019 on the prevalence of maternal risk factors related to neonatal abstinence syndrome in a commercial claims database. And the analysis of the commercial claims database from 2011 to 2015, it revealed a group of pregnancies that ended in live births. The use of prescription drugs such as opioids and SSRIs and antipsychotics or non-prescription related variables such as smoking or substance use disorders during the antepartum period was one example of a maternal risk factor that was of interest. So, how do we put all this research into practice? When it comes to benzodiazepine withdrawal in infants, there are various things that doctors need to keep in mind, including prenatal care. We need to make sure our mothers are keeping up with their prenatal appointments, and this should include screening for benzodiazepine use by the expectant mother. We need to monitor benzo usage. This should be a part of a comprehensive drug history that is part of a comprehensive evaluation. It is crucial to check for irritability, tremors, feeding problems, and respiratory distress in neonates as soon as possible after delivery, since these might be an indicator of benzodiazepine withdrawal. For multidisciplinary management, nurses, social workers, obstetricians, neonatologists, pediatricians, and other healthcare providers need to work together to manage benzodiazepine withdrawal in infants. We need to provide supportive care, and it's essential. It's an essential component of benzodiazepine withdrawal management for newborns. This involves making sure the baby has enough to eat and drink, and the atmosphere is conducive. How do we apply this to practice? We want to make sure the pharmacological treatment is available to alleviate symptoms and avoid problems. Pharmaceutical treatment may be required for those experiencing severe benzo withdrawal. We want to monitor and we want to follow up. We want to check for changes in feeding habits, monitor vital signs and symptoms, and observe newborns experiencing benzodiazepine withdrawal. Healthcare providers need to check in with parents at regular intervals to see how their babies are doing and provide advice and support. Education and counseling should also be provided. Counseling and support should be available for women with substance use disorder, and healthcare practitioners should inform pregnant women about the dangers of benzodiazepine use during pregnancy. Treatment options. So, on top of providing medication for the moms, in some cases, the doctor may recommend medications to help an infant cope with withdrawal symptoms and provide some relief. These may be administered orally or intravenously. As the body adjusts, the infant may gradually be given less medication. To reduce the likelihood of harm to the unborn baby, it is recommended that pregnant women who are addicted to benzodiazepines seek the advice of experts who can help them with how to use this medication. Caring for baby. So we want to put an irritable infant to sleep in a dark environment. We want to wrap the baby lightly in a blanket or swaddle them if they're crying a lot. Increase the frequency of diaper changes if the infant develops diaper rashes, and give smaller portions more often if the infant is having problems eating. Food for thought. So in all of this, we never came across any medications that were recommended for benzo withdrawal in neonates. One paper specifically referred to phenobarbital, but there is no protocol or approach for this. Is there a baby benzo taper? Also didn't come across any work done with regards to this. There's no standardized process for treating benzo withdrawal in neonates. What about if mother is taking benzos and is breastfeeding? So one paper did mention that women can take benzos and breastfeed, but further research is needed because there's no outcome, right? We don't know what the outcome is. Okay, so in conclusion, all this work just highlighted that opioids have long been the focus of neonatal withdrawal syndrome studies due to their common usage and the fact that they may cause withdrawal symptoms in both the mother and the baby. However, further studies are needed as there is a significant gap in the current study literature regarding the newborn withdrawal symptom and benzodiazepine withdrawal due to the poison drug supply. And there is fewer studies that have focused on benzodiazepine, despite the fact that there may be induced withdrawals symptoms in infants. Yeah, I have an extensive list of references. And I just want to close off by saying that there is a support line that is available 24 hours a day, 7 days a week for anyone with questions with regards to substance use. Okay, that takes me to the.
Okay, Karen, for highlighting such an important concern, especially in the context of the toxic drug supply, where we know we've experienced definitely moms going into withdrawal and that. So yeah, so hopefully we get to see more research coming out in the future. But I just wanted to open up to people sitting in the room today and then also online. Let's see if I just need to navigate to the chat here and see if there are any questions from the audience. All right. Questions, comments, reflections.
Has anyone come across benzo withdrawal babies?
Yeah, we're from the Trinity NICU, and I would say that this is kind of a shared concern among the province, and how we support these infants with the regulation of breathing. That's our first goal. Often they have IVs because we have to get breathing organized first. And once they get stabilized and they're ready to feed, they're showing signs, but they're also very dysregulated and disordered. And they're finding, not just at our site, but across, especially up in the north where there's limited everything, a lot more babies are NG fed for long periods of time, which often disrupts that rooming in and bonding because of that higher needs for the baby. And then with that, a lot more diaper rashes and a lot more gut upset. So I think over the span of my career, it was improving, and then now we've seen like back to how it was, and just with the symptomatic babies that are so symptomatic, it's like they're quite rigid, and the diaper rash is so bad. And that we thought we were seeing it, but we put it together with the province. It is like very apparent that this shift in the
it's not opioids anymore.
No,
yeah, it's not opioids anymore.
I think, but we all see it in our little silos. So the NICU teams are just like, oh my gosh, like this is what we have to do now. But we really do expand the lens and have that conversation with bigger groups and with like shared teams. It's just so nice that every service is kind of coming together, and hopefully the people that are able to do research of this kind can support that.
I want to say my initial project was repetitive transcranial magnetic stimulation. And, and I did a stint at FIR, and I came across a baby who was suffering, is the word, you know? I was like, no, I gotta use this to get my voice out there. Like there needs to be more work around this. We need to shine the light on what's going on right now for benzo withdrawal with babies.
Yeah, thank you.
Hi.
Ask a little more about how they were treating that particular baby that you worked with at first.
So he started off on morphine, so they were doing morphine, and then throughout the night, when we came in on the morning, they were like, this baby had been crying all night, wouldn't feed, and I'm like, that sounds like benzo withdrawal. So there you have the pediatric team that addressed the concerns for the baby, and you have the doctor who can address the concerns of the mother. So when they came for rounds, we kind of like had a little, hey, do you think it's benzo withdrawal? And they were like, yeah. And that's how the phenobarb discussion came around. So we gave him a small dose of phenobarb and he started to perk up. And then that's how we realized, oh yeah, this is what's going on. Yeah. So they did address it, but it's like, you know, it's all this consultation because no one wants to take that initiative to say, hey, I'm just gonna throw some pheno at this kid and see what happens, right? Because there's no process, there's no protocol. And what if it goes sideways? Then what happens, you know?
And you're using adult meds.
Yes.
And you're correcting for weight, but because there's no understanding, is that the right way to go?
Yeah.
Which we always do.
Yeah.
For little people, we just make little doses, but what is that?
Yeah.
Look like?
Yeah. So yeah, definitely a topic that we need to discuss a lot more right now because it's becoming quite apparent. I just returned from Prince George myself, and yeah, it's the same there now too. Like they're just starting to realize, whoa. Yeah.
So definitely opportunity for
Yes.
future work and making sure that we have sort of more standardized assessments and protocols to treat babies similar to what we're doing in adult populations as well.
Because all the research did is it did show that baby being exposed to benzodiazepine poses risks to the baby, right? That's what all these research showed. There's no research for how do we treat the benzodiazepines, right? So when you Google it, you're going to see all this that I already did here, and it's all about the risk it poses and what it does to baby. But there is nothing that says, okay, here's how we treated it, right?
Well, I wonder too if it's the prescribed amount for maternal controlled amount versus continual exposure at uncontrolled amounts.
So you can't even measure it, right? Because if someone's taking 0.5 of clonazepam TID for the past 10 years, and then someone's doing fentanyl that's got benzodiazepines in it, first off, we don't know what type of benzodiazepine. What's the strength of it? Or is it tranq? Who knows, right? It's just so unregulated. It's very hard to pinpoint it. So I think that too, like if they did decide they were going to do a research, what are those variables going to look like? Like, how do they measure this? You know, it's going to be crazy.
Right. Great discussion. I just wanted to highlight on the chat. So Ron saying that my experience on First Square was that babies exposed to benzos could be supported by rooming in with mom and feeding support, etc. Thank you so much for that comment and sharing your experience. And then also there was a question from Enya. Will there be a discussion regarding how fetal heart rate present? Oh, sorry, that doesn't make sense on
MST?
Yeah.
Sorry, Anya.
Sorry, I think I just need clarification about NST, that's all. Oh.
Nobody? NST?
NST would be like a fetal assessment while the patient was still pregnant, and how that would present. Likely.
Non-stress test.
Yeah, if maternal vital signs are depressed in any way, then we see it with the fetus, but that's as much as we would act on, yeah.
Great. Thank you for clarifying, Anya. Great.
Okay.
All right. Any other last questions, comments, ideas?
Would there be a role, like from what your experience, would there be a role in a team like to have a pharmacology addictions medicine, or could the perinatal addictions team also be the leaders?
You
for
might be
these?
onto something there. I think, we have it as a specialty for adults. Why not for the neonates, right?
I just feel like that population, we're doing so much to really pinpoint and nuance care in perinatal, like why not continue following the dyad? Because it might be together, but it also might be NICU, mom, but then they will be together eventually.
Yeah.
Yeah, great. That's a great suggestion. Thank you
Great
so
idea.
much for sharing.
Beautiful.
All right.
Okay,
Thanks,
you got the gift of
everyone.
time. Thank you so much for coming.
Thank you.
Okay.